Hi, this is Emily Brand, and this is my presentation on my IPE interview and medication affordability. Starting with my IPE interview with Jordan Kay, she's an OT, occupational therapist. It started with me asking her how pharmacology affects her as an OT on a daily basis. She focused a lot on pain medication, especially in the inpatient setting. She said that she often likes to check with nurses to make sure pain medicine has been given prior to therapy to make sure patients can move better and benefit more from their therapy. She also said that sometimes pain medication can hinder therapy if it makes them sleepy or groggy and they may not want to participate in therapy or not do it correctly. She also said that steroid injections can impact her job. She says a lot of the times that patients that she'll see, if they have recently have gotten an injection, will move better than prior to it. Next, we talked about how a healthcare team involving pharmacists and nurses better served patients. She relayed that all members of the healthcare team are important because everyone sees the patient from a different perspective, and this is helpful in team rounding. She was really in favor of pharmacists being involved in these team rounds because they are able to monitor for drug interactions, which could be impacting the patient's health. She also said that interdisciplinary teams improve discharge planning because they're able to come up with a list of medications, therapies, and do education and work together to make sure the patient has a good transition of care. Next, we talked about how nurses help patients adhere to their prescribed regimens. She was very forthcoming when she said that herself, as an occupational therapist, had very limited knowledge of medications, that she felt very uncomfortable with knowing anything about them. She even went so far as to say that she would be super nervous if she ever had to administer a medication. She talked a little bit about how, since she didn't know much about medications, she didn't see the point in why a lot of people are taking what she may consider unnecessary medications because she's uneducated about this area. And this is why she said that nurses are very important to the healthcare team because they have a lot of knowledge on how medications work and their side effects and interactions, and are able to educate patients on these items so that they know what they're taking and why they're taking it. Some things that I took away from my IPE interview with Jordan are the benefits of an interdisciplinary team from a non nurse point of view, the fact that OTs need nurses and nurses need OTs, and we all need to work together as a team because the patient needs all aspects of the healthcare team. I learned that nurses are good communicators, especially as seen by someone outside of nursing, that patients in other disciplines may be limited on medication knowledge even further than I thought, and that we should over-educate about medications because we know so much about them. We assume that patients know, but in fact they really do not, and this may make them not take their medications correctly. The next part of my presentation is on medication affordability. Proper education helps increase adherence to prescribed regimen. This is why Jordan in OT said she believes that nurses play a huge role in educating patients. In fact, today, some payment models link payment to patients' outcomes and adherence instead of fees for service. This causes some providers to refuse to care for non adherent patients, which is a shame because many times non adherent patients are simply non adherent due to costs of medications. These non-adherences can lead to health complications, which equals hospitalization or emergency care and increased costs then due to simply not taking medications. Cost of medications, in addition to lack of education and social and environmental factors, is a huge reason for patient noncompliance. I have an example here from the Blue Cross Blue Shield study in Texas from the years 2008 to 2011 of approximately 49,000 people who were surveyed that were prescribed statin therapy only showed 48% compliance. And multiple studies affirm that lowering copays increase medication compliance for a variety of diseases such as diabetes, coronary artery disease, and hyperlipidemia. And also, in a study by the NCHS, showed 8% of adult Americans do not take their prescribed medicines as ordered simply due to the cost. Here are some prescription medication cost statistics. From 2009 to 2016, the price of EpiPens increased by 500%. Prices of more than 100 drugs used to treat chronic conditions have more than tripled in price since 2006. 7.1 million older Americans live below the poverty level and must decide to pay for medicines, rent, or food. In 2018, elderly Americans who suffer from chronic conditions spent on average $30,000 each for medications. Some of these were covered by insurance, but it's still how much the medications cost. And 6% of Americans less than age 65 choose to skip on medications due to costs, even though they may have private health insurance, and 10% of Medicaid recipients do not take their medicines due to cost. Here's some ways we can take action. Hospitals are helping to control inpatient stay costs for medications despite their increased costs by way of inventory control, taking frequent inventories to make sure they don't have an overabundance of medication or not ordering too much, managing their formulary to make sure they're keeping the drugs on formulary that are the lowest cost to patients, and performing drug utilization reviews to make sure the medications that they have are being used, and if not, perhaps ordering them in lower quantities to save cost. Therapeutic interchange for volume discounts. A lot of times, hospitals will get discounts on ordering a lot of medicines and just interchanging them for the patient's perhaps brand name medications when they come in. Um, Pharmacists and doctors alike should exclude new medications if they're too costly and not forget about older medications, especially if they have the same active ingredients. And there are calls in the political realm for the Health and Human Services Secretary to utilize the 55 million Medicare beneficiaries as a bargaining power against Big Pharma in order to lower prescription drug costs. So, what can patients and consumers do to help lower their own costs out of pocket? They can have their family doctors determine the medications that they really need, especially if they see multiple doctors or specialists. They can try to see what lifestyle modifications they can make that may take place or reduce the need for medications. They can check to see which medications are preferred drugs by their prescription plan. Check with their pharmacist to see if pill splitting is an option. Sometimes pills that are in a larger dosage will be cheaper, and then the patient can just invest in a pill splitter and have the dosage that they need. They can also ask their doctor or pharmacist if there's a similar medication in the class or a generic drug is cheaper. And shopping for deals is always a good idea at different pharmacies to see which prices are better for the medications they need. This is a little diagram I made for how medication costs affect interdisciplinary teams. The first thing is, of course, increased medication costs. What does it do to adherence? It decreases patient adherence because of the ability to afford their medications, and this in turn may increase health complications, which increases healthcare spending by way of emergency room visits, having to use more medications to limit their symptoms and cure them, hospitalizations, and this in turn decreases provider availability in all across the board in all members of the team. And the end result of all of this is overburdened healthcare workers of all disciplines, which may ultimately lead to burnout. So, increased medication costs can have many consequences, from patients having worse health and not being able to afford food or rent to eventually healthcare workers being bogged down by extra sick patients who may have not contracted the disease or had worsening disease if they would have simply taken their medications if they could afford them. Thank you for watching my presentation. Here are my references.